We're going to go with James for 123.
Drugs known as calcium channel blockers, such as I don't know how to pronounce it. I'm just
Nifedipine.
Nifedipine can be used to. I have researched this drug up, and I'm going to go with A. Decrease the force of cardiac contraction.
Yeah, that is correct, right? So for the most part, right? Remember we talked about role of calcium in muscle contraction. What was calcium doing? Anyone can tell me? Or you could tell me, James.
Well, that medication itself, it lowers the blood pressure by relaxing the blood vessels, so the heart doesn't have to pump as fast.
Yeah, but
so
what does the role, like, let's just say, forget about the medication. What does calcium do for a muscle? Remember what we talked about muscle contraction in the musculoskeletal chapter?
Mm-hmm.
What was the role of calcium for like a normal, healthy person, no pathology?
Honestly, I'm just gonna be honest and say I forgot.
Okay.
But I would believe that it helps. I think lower their their ability to spread. I mean, I don't know. Maybe I'm explaining it wrong.
Okay, let me see. Anyone recall from musculoskeletal chapter what's the role of calcium?
It depolarizes the cells.
But tell me specifically where does it bind to?
Is it troponin or tropomyosin? Or probably has to do with actin and myosin.
Yeah. So you are correct, right? So we have the binding of calcium, right? And the binding of calcium is what actually causes the myosin head to then dock on the actin filament as the right. Tropomyosin is moved out of the blocking sequence. So that causes musculoskeletal contraction. But guess what? Cardiac myocytes, they also have actin and myosin filaments, right? They are also muscles. So role of calcium is causing contraction, right? So if we have a lot of calcium, right, we have more contraction because calcium is going to come in from the outside to the inside, causing the contraction. And now we give you a drug that blocks your calcium channels. If you block your calcium channels, which nifedipine, diltiazem, right, cardizem, these drugs do that. If I do that, I'm going to decrease force of cardiac contraction. Now, sometimes you're going to be working in the field and you have a patient who has, let's say, a supraventricular tachycardia, SVT, and you call medical control and they say, all right, go ahead, give diltiazem, but prior you giving this medicine, give them some calcium. Why do you think they ask you to do that?
Maybe because it slows down the contraction of the heart. Basically, like it'll help the cardizem bring down the heart rate.
But why preload them with calcium prior to giving a calcium channel blocker? Which kind of, makes no sense, right?
Well, that kind of helped to rule out the issue to make sure that's functioning.
Rule out what, Lindsay, you said?
To make sure that that's what's functioning, so that's to help figure out if that's what the issue is.
Not really. So the reason they give it is you could attenuate the possible hypotension, right? So those drugs can also work on the peripheral vascular resistance, systemic vascular resistance, right? Or PVR, SVR. And if you give calcium or you preload with calcium, you can attenuate some of the hypotension that you may see with that. So hopefully the drug exerts its effects on the cardiac cells, just blocking the calcium channels, slowing down the deep, calcium influx and slowing down your heart rate. And the calcium that's given intravenously hopefully will attenuate some of the hypotension that you get. That's why if you look at the medication, they'll say you could give diltiazem only if the blood pressure is normal or elevated. They don't say you could give it in setting of hypotension because they know that this medicine will lower blood pressure. But if you pre-treat them with calcium, you could attenuate some of these effects of hypotension with calcium. So that's why they may tell you to do that. just so you guys are aware.
Is that because it's acting on the muscles in the body, like so that
Yeah.
it's not like a systemic hypotension?
Yeah, it doesn't cause this profound effect on your systemic vascular resistance, where you could have profound vasodilation, right? And you could essentially drop their blood pressure even further. I would say give these medications slowly. Don't like fast push anything. Have them on the monitor and put your blood pressure reading, right, non-invasive blood pressure reading, to the lowest number you can. If it's every 2 minutes, that's what you're going to do. If you have a even lower setting, like every minute, you could do that, so that your machine is automatically acquiring blood pressures as you're, giving this medicine, so that if all of a sudden the patient becomes hypotensive, or like, is now close to that 90 systolic, I would stop the administration of the medicine, right? And then perhaps you may need to give some fluid boluses to resuscitate them. So be very cognizant anytime you give any antiarrhythmic medicines. Always monitor patient's blood pressure every 2 minutes or faster if you're able to. Any point they come close to becoming hypotensive or that borderline of 90 systolic, I would cut off the medicine, right? Stop the medicine, whatever it is, amiodarone, lidocaine, diltiazem, whatever antiarrhythmic is, and make sure you resuscitate the patient back up, because if you just let this medicine run or the drip run and you don't notice, you're going to have a cardiac arrest on your hands. All right. Number 135. Who was the last person to go?
That was me.
James. Okay, so we are up to Jackson for number 135.
Define
mediastinum. So one hint I can give you is they look at that on chest x-rays, right, when the patient comes in, to rule out possible aortic dissection.
Yeah, I'm reading the answers. C.
The mediastinum is the region anterior to the sternum during cardiac pulmonary resuscitation. So.
Oh wait, sorry, I read that wrong.
So for this question, the correct answer is B, right? So the mediastinum is the region between the two pleural cavities that contains heart along all the great vessels, thymus, esophagus, and trachea. So basically has all the structures besides the actual lungs, right? If we say thoracic cavity, then we're going to include the lungs with it. So the mediastinum, right, is basically like the center of the chest box, which has all the great vessels, right? That's why when they do chest x-ray, possible aortic dissection, right, that's where they will look, for possible widening of the mediastinum. Let me see what else I wanted to ask you guys. About that. Well, what do you think? You get a patient that comes in to the emergency room with acute coronary syndrome complaint or ACS. Why do you think in the ER, right, they try to do a chest X-ray? They don't always get to do it, but they try to do a chest X-ray. What do you think they're trying to look? Because as you know, right, you're not going to see any black, like you're not going to see a thrombus on the chest X-ray. You're not going to see a coronary thrombus on it.
Can you just say it? Possible blood from the dissection.
So essentially they're trying, not just the dissection, they're trying to find any other possible causes of acute chest pain that the person may have. So such things as a pneumothorax will show on X-ray, right? You may have the aortic dissection. You may have pneumonia, right? Pneumonia can show you consolidation on the chest X-rays. You may have congestive heart failure, which will show you like fluid, right? Blood, fluid, broken bones, all that metal is seen on X-ray. So they're basically trying to see if there's conditions other than the ACS that are evident on the X-ray, which patient will need other type of care, right? If you miss it. So I can tell you that if a patient has, dissecting aortic aneurysm or has aortic dissection, they'll need a thoracic surgery. They're not going to need to go to the cath lab for stenting. So if you miss that and you send the person to the wrong, place, they can essentially die on the, cath lab table. They're gonna, put the catheter in, and then they'll realize that they're dissecting aorta. So then they have to call the thoracic surgeons. They have to get the OR ready. So that's why they do that, to basically find other conditions that the patient may have, right? All right. 138, we are going to go back to Ian.
So from superficial to deep, name the layers of the heart wall. Superficial, starting with the pericardium, then the myocardium, and then the endocardium.
Yeah, that is correct. E is the correct choice. All right. 139, we are at Irene.
Okay, why is it important that cardiac tissue contain many mitochondria and capillaries? Okay, so mitochondria, the powerhouse of the cell, and cardiac tissue is very demanding.
Correct.
Cardiac tissue primarily uses mitochondria for glycolysis, generate because provide. I like C.
Okay, so let's see. C, cardiac tissue primarily uses mitochondria for glycolysis to generate ATP and capillaries to provide oxygen and nutrients for this process.
No, D is better.
D is better. I agree. And why is D better?
Now that I read it, apologies.
All right, because why is it better?
Aerobic respiration, generating ATP, capillaries provide oxygen nutrients for this process. That's the only valid one.
Yeah, because if you think about it, right, where's the actual ATP produced? ATP is produced past the glycolysis point, right? So first we have the glycolysis, then it's going to go into the Krebs cycle, and then it's going to go into the electron transport chain to actually make ATP. If you think about it, in the glycolysis pathways, I think I explained to you, you only make 2 ATP. That's not a lot of ATP, right? So the glycolysis here is going to make 2 ATP, versus when you send it to electron transport chain, you get 30 to 32. Yeah. So
I remember that from last time.
Yeah, this is way more effective. So for 139, the correct choice is D.
Okay, good.
All right.
Sorry, I had to think it through.
Yeah. 141, we're going to go with Milan.
Which of the structures collect blood from the myocardium, and into which heart chamber does the blood flow? It is coronary veins that collect it, and it goes into the right atrium.
Correct. So C is the correct choice, yes. So collect blood from the myocardium, carry it to the right atrium. Makes sense, because then it's going to go to your lungs to get oxygenated, and then the cycle repeats itself. Good. 142 with Lindsay.
Describe the areas of the heart supplied by the right and left coronary arteries. Oh, I'm looking at it. Let's see. Okay, the right coronary artery supplies blood to the right atrium and right ventricle. The left coronary artery supplies blood to the left atrium, left ventricle, conducting system, and interventricular septum. See?
Which choice are you saying?
C.
C? So let's see here. The left coronary artery supplies blood to the... There's one thing that's not fully correct with the choice C, right? Choice B is slightly better. Tell you why. Because of this.
Oh, because of the both. Yeah, I knew one of them did both ventricles. Okay, I was thinking that the left side did both ventricles.
Yeah.
Okay, the B.
The right coronary, there is both. There is blood supply. If you look at the posterior wall of it, the crossover, for the EKG, for the 12-lead EKG purposes, if what you said would be fine, right? Because on the 12-lead EKG, you're basically gonna subdivide it like into the walls. But truly speaking, there is some branches. And you know what? To be quite honest with you, if a person sustained a heart attack or they had stents in the past, they may have collateral circulation where they basically make new branches that supply blood to other portions. So you wouldn't truly know for a fact what's supplying what unless you do take them to the cath lab and actually perform the PCI procedure and push dye and see what's being highlighted on the screen on the fluoroscopy. But for this book, they chose B as the choice, and I think it's because of that. It's just more inclusive. Okay.
Yep, that makes sense.
All right. After we have James for number 149.
This is going to be the hard one right here. Okay. This one is compare arterial sclerosis. I can't pronounce it.
Arteriosclerosis and atherosclerosis.
This is, I will go with A. Arterial sclerosis is any thickening and toughening of artery walls. Sclerosis is a type of arteriosclerosis characterized by changes in the endothelial lining of the formation of fatty deposits or plaque in tunicomania.
Yeah, that is the correct choice, right? So this athero, right?
I ain't going for it. I guess this. I'm not even gonna lie to you. I guess
the athero is the formation of plaque, right? And this arterio, this is the hardening. So if you look at it, right, one is hardening of the vessels, the other one is a plaque or fatty deposition on the lining of the vessels. If you guys ever get a chance to go to a cadaver lab, right, or sometimes you had morgue rotations, they will open up the thoracic cage and they will look at the aorta, and those patients who had coronary artery disease or they had extensive arteriosclerosis, they'll push on the aorta, right, like to try to collapse it, and it's like it feels like eggshells, right? Like imagine like you take eggshells and you like you cook an egg and you basically trying to break the eggshells with your fingers, right? And you feel it like collapsing under your fingers, it's breaking apart. They call it friable plaque, and that's secondary to that hardening, right? Arteriosclerosis and deposition of fat in the lumen from atherosclerosis. So those are the combination of things that happen. Oh, by the way, all of us are sitting here. All of us right now have some amount of arteriosclerosis and atherosclerosis that is in our vascular system. It's just the level is not enough to cause any pathology. But all of us at this point, right, we have all that's ongoing. And when it becomes a problem, when it's reduces the blood flow to your myocardium. But if you remember, athero means plaque, right, or formation of these fatty deposits, and arterial is the hardening. I think you should be fine going forward. But yeah, A is the correct choice. We're going to go 161. James was the last person to go. We're going to go with Jackson.
List the important features of the ECG and indicate what each represents. Um, it's not A, B. Um,
That is correct. But the better way I would go about it, right? If I would look at the first choices, right? Which one makes sense? So we know the P wave is not atrial repolarization, right? So we can right away exclude A and B, right?
yeah, it
And
has P
so,
wave
mhm.
peripheral depolarization.
Yeah. So P wave is atrial depolarization. So now we given that we can also eliminate E. So now the next choice, right? We got to look, right? Is QRS complex ventricular depolarization?
Yes.
Yes, it makes sense. So we cannot eliminate anyone just yet. Then we got to look at the T wave, right? So what is T wave? Is T wave ventricular repolarization or T wave atrial depolarization?
It's repolarization.
Yeah, it's repolarization. So then we are at choice C, right? So T wave is ventricular repolarization. That is correct. So that's how I would go about choices like these, right? Just go by process of elimination. Okay. So we'll do that. Lydia, would you like to go with number 162?
Sure. Why is ventricular fibrillation fatal? I would say B. Ventricular fibrillation is fatal because ventricles quiver and do not pump blood to the systemic circulation.
Yeah, that is correct, right? So the in the fibrillatory phase, they are not functional. They don't contract, right? They're quivering. Actually, does anyone know what's the heart rate in fibrillation? How fast is it?
It's like 250.
More like 350, 450, right? Along those lines, yeah. So it's beating, or it's not really beating, it's quivering so fast that there's no time to fill, and it's the heart rate is not sustainable basically it's not sustainable with perfusion, so that you go into, you syncopate, you fall to the floor, and yeah, so I would say in excess of 350, maybe 450, and they don't have enough time to fill and pump the blood. So that's why we basically have to do CPR in order to circulate the blood, and then we have to defibrillate them, hopefully change the rhythm, or basically change the rhythm with electrical therapy to a more perfusible rhythm.
Is there right-sided backup?
What do you mean by right-sided backup?
Like the right side of the heart, does the blood back up?
During cardiac arrest?
During VFib in particular?
Not per se. You basically have blood stasis. You don't have any blood flow to begin with. So you have blood stasis as the heart is not contracting. So then what you're doing is then you're physically pressing on the sternum in order to execute the motions of the heart. So when you press, you eject the blood, and when you pull back to get that good recoil, right, you're acting as a diastolic phase, so hopefully heart refills. That's why during CPR we tell you, right, you wanna push deep, right, but we also want to make sure you do chest recoil. If any of you practice on the new mannequins that we have with feedback, you basically see, right, like there's like a sensor like this, and there's an arrow, right, that will show you if you're not pushing it deep enough. And this sensor will basically move up and down every time you pushing on the chest. So if you're not getting adequate recoil, these arrows will pop up telling you either you are, resting your hands on the chest, or you pushing too deeply, right? You want to make sure it's at least 2 inches. So the purpose of this device is basically to train you to see what adequate depth and good recoil is, and it's not per se for the right backup. It's more of blood stasis throughout the body. It's overall stasis.
Mm.
Okay. 168. We're gonna go back to Ian. Ian, are you here? Okay, no, Ian.
Can you hear me? Can you hear me? No, I'm here. Can you hear me?
Go ahead. Yeah, I could hear you. Go ahead. 168.
Okay, compute Joe's stroke volume if his end systolic volume is 40 ml and his end diastolic volume is 125. So the stroke volume formula is EDV minus ESV. So that gives us 85B.
So for this, yeah, you are correct.
Hello? I can't hear you.
Yeah. I'm just drawing the stuff out. Yeah, should probably do it like this. So basically, what this is asking you, right? They provided you with both the end diastolic volume, so that's the volume during end of diastole, and they provided you end systolic volume once the heart has contracted, right, and the blood has ejected. So the difference between these two parameters is what essentially is your stroke volume. So here, everything is in ml, right? 40 ml, 85 ml. Right? So that's basically what we're calculating here. So that is correct. All right, next one, we're gonna go with Irene.
Okay, arrange the following structures in the correct order as blood would pass through them. Okay, we're going to start with the right atrium.
Okay.
Going down to the right ventricle. Going to the pulmonary arteries. Once it hit the lungs, comes back pulmonary veins to the left atrium and left ventricle systemically. Okay, 3. So what numbers did I say? We have 5. No, I don't see. We don't start with the 5.
Yeah.
Okay.
So before think about this. Before you get to the right atrium, right?
Yeah.
Before you get to the right atrium, where is all the blood collecting or is coming from?
Superior, inferior vena cava. So
Which
we
is-
start with 3.
Which is essentially systemic veins, right?
Right.
So
Okay.
you start. So I would say 3 would be my first choice. And
Okay.
then
So we got B then.
yeah. So this eliminates everything else pretty much, right?
Right.
And then we got
3, 5, 4, 2, 6, 1.
we just got to make sure, right? Systemic veins, but then what's 5 says right atrium makes sense. What's so then we have right ventricle makes sense. Number 2 pulmonary arteries, yes, and then pulmonary
Okay.
veins, left atrium. So yeah,
Okay.
everything else makes sense. So
So I
if
have
you-
the right lottery numbers.
yeah. So if let's say you start with the right atrium and then number 5 is not there, then you have to look right what else can be before it. So systemic veins.
3, 5, 4, 2,
B is
6,
the
1.
choice
Thank you.
here.
Mhm.
We're gonna go with Milan with 35.
The vascular resistance refers to all the factors that resist blood flow in the entire circular system.
Which choice did you say?
E.
Vascular resistance. So that's not a bad choice, but to be more,
Is it D?
yeah, to be more like complete is the total peripheral resistance. So it's not that vascular resistance. Like I understand what would you say, but total peripheral resistance, or we say PVR or SVR, systemic vascular resistance. So they're referring to all the factors.
So peripheral is basically the moment it leaves the heart, right? It doesn't matter. Okay, that makes sense.
So essentially, if I were to diagram this out, if this was your heart, what truly affects the systemic vascular resistance is these arterioles. Arterioles is what actually has the smooth muscle to contract, narrow the diameter of it, right? And by doing so, this will basically increase my afterload. This will also increase my systemic vascular resistance. This will increase my peripheral vascular resistance. These are the arterioles that are actually contracting. Why? Because if you think about it, the lumen of the aorta is not so narrow where, you know, the contraction of it will cause profound vasoconstriction. It's the arterioles on the periphery. That's why someone who is in, you know, hypoperfusional shock, first you see peripheral vasoconstriction. So if you touch their limbs, right, arms and legs, they're going to be cold. They're going to be cold. They're going to be cool to the touch. They may be even cyanotic, right, in this case. But the trunk, right, and the core is still somewhat warm. Some perfusion still going on. And the whole purpose being is these are the arterioles that are vasoconstricting, and that's what governs, right, the total peripheral resistance. So D is basically, it's a more complete choice here. Okay, 39 is Lindsay.
The main control of peripheral resistance by the vasomotor center occurs in the. I wasn't sure about this one.
Mm-hmm.
I don't think it's capillary because they don't have like muscle in them.
Yeah, is that that's not the capillary?
Yeah. I would guess either artery or vein.
So here it's actually the arterial,
Oh,
right?
arterial.
Yeah. Because if we go from the big artery like aorta, right? It goes aorta, then it goes into artery, then it goes into the arteriole, then it goes into the capillary, then it goes into venule, then it goes vein, and then it goes systemic veins like your inferior superior vena cava. So if you move through this process, right, the arteriole is actually what will vasoconstrict or adjust secondary to the vasomotor centers, right, and your body's needs, right, and also it will respond to the medications that you provide, such as epinephrine or any type of alpha blockers, right. So arterial is what's governing that. 45, we're going to go with Jackson.
I have a quick question about the last one.
Yeah, go ahead.
Do the venules, do they even have the ability to contract, or that's just a special feature of the arterial?
You could mobilize. So if I were to draw, let me do this. Actually, make it green. And then we're going to make this blue. Jugulars. And it goes to your lungs. So usually when we talk about the flow, right, we're going to start with the major artery, which is the aorta. Then at this point, right, is going to start to branch into the bigger arteries. Then at this point, is going to go into arterioles. Here, green was going to be the capillaries. Here, we're going to say it's going to go into venules. Then it's going to go into veins. And here we're going to say this is the inferior vena cava, this is the superior vena cava at the top, right? And goes into the right atria. So when you cause vasoconstriction, right, by giving, let's say, a pressor, truly speaking, right, you're gonna vasoconstrict here in these arterioles. So the sphincters here will contract, will not allow forward blood flow. However, you can also mobilize through the veins, and the systemic veins. So there is some squeeze that these drugs and your sympathetic response can cause. And what this does, even though it constricts on the venous side, it's not going to cause per se like increased vasomotor tone. What it's going to do is going to mobilize more preload to come to your heart. So because we said about 60% of your blood volume is housed in your systemic veins, which act as a capacitance or a tank. So this is the tank of blood that's here. So if I give you some pressors, right, and I vasoconstrict you, the predominant is going to be here. The predominant work is going to be here, but it also is going to increase your cardiac output. How does it do that? It does that by mobilizing your veins, and it mobilizes the 60% of your storage to move more, right, blood into the heart, so you augment your preload. This is why also, right, in a setting of, let's say, cardiogenic shock, before you give your pressors, you are often taught to give about 250 mLs of fluid, reassess, and give another 250. So you're augmenting their preload, right? You're giving them basically a little bit more to tank them up, and then you're going to give your pressor to basically exert that vasoconstrictions on it. So you could, truly speaking, the systemic vascular resistance is going to be governed here at the arterial side, but you can mobilize your some blood storage on the venous side to basically get a bigger preload and then vasoconstrict it further. All right, does that make sense?
How do you give those? Yeah, Nick, but how do you give the first 250 cc's? Is that a drip or is it like a fast push?
So basically, let's say you have a patient who you suspect is in cardiogenic shock and their blood pressure is low. You're basically going to start IV access and give them 250 ml IV bolus. So basically, you open the fluids. So it's basically just running, infusing fully, wide open.
Fully. Okay, so it's quick.
Yeah.
You need to get that in there quick.
Yeah. Okay. Wide open. And then what I would do is I would reassess their lung sounds to see that they did not develop pulmonary edema, because as we know in cardiogenic shock, your heart may not be pumping as well. If there's no pulmonary edema, I'll probably give them another 250 and reassess my blood pressure. If that is enough to fix my blood pressure and my hemodynamics, I will keep them. And if not, then I will have to get a press on board. So then I'll give them, let's say, maybe a norepinephrine to vasoconstrict them. And that should bring up my MAP and my SVR.
All right. Yeah, thanks, Nick. That was helpful.
Yep. Okay. We are, I think Lindsay went. So we are up to Jackson for 45.
Is my go?
Did I skip you? Okay, go ahead, James. 45.
All right, where's the blood pressure the highest? I'm going to go with A, artery.
Artery is correct, right? That's when we measure 120 over 80 or whatever it may be, 160 over 90, that's where we measure. So artery is the highest. Okay, we're going to go 46. I think next one is, oh, I see you guys raise your hands. Never mind. Kayla, I see your hands is up. For 46.
The difference between systolic and diastolic pressures. Is it a E or D?
So pulse. So the difference between, so they're asking is systolic blood pressure minus diastolic blood pressure. Mm-hmm. So this is actually, this is known as the pulse pressure.
Oh.
So here is sees the correct choice. You will see for the next question, right? How that this is important. All right. So next we have, okay, I think we start back from Ian for number 50. And you guys can use your calculator if on your phone if you like to. I'm not making you do this.
Okay.
So first, before you calculate, we have to get the formula, right? So do you remember the formula for MAP?
It is 2 times dBp plus SBP over 3.
Yeah, that's good. You could use that. Another formula is the one that I was just explaining. 1/3 of your pulse pressure plus your diastolic blood pressure. So 1/3 of your pulse pressure. So this is your pulse pressure, right? So systolic blood pressure minus diastolic blood pressure. Why I like this formula better is not because the other doesn't work. It's just this gives you that term, pulse pressure. And pulse pressure becomes very vital, especially when you talk about conditions where you have narrowing or widening pulse pressure, right? When you have, let's say, a cardiac tamponade with narrowing pulse pressure, or you have, let's say, a Cushing's triad where you have widening pulse pressures. So the pulse pressure is becoming an important term. That's why I prefer this formula, but you guys can use any one to calculate this. So
yeah, that one's easier too. So it would be a B, 100.
Yeah, 100.
So a third of 30 is 10 plus 90 is 100.
That is correct. So if we did this formula, right, systolic blood pressure minus diastolic blood pressure, we said 120 minus 90, which is 30, right? 1/3 of 30 going to be 10, right? And then the diastolic blood pressure we see is 90 here. So 10 plus 90 equals 100. Okay. So now, Irene, would you like to do 193? You could use
absolutely. Sure.
You could do your calculator.
I did. I used my toes.
Okay.
Calculate the mean arterial pressure for a person whose blood pressure is 125/70. So what I did is the systolic times 2 the diastolic over 1/3 or 3. So I came up with 88.3, which is C.
That is correct, right? I would say make sure you know the formula, committed to your memory. On the REMAC exam, I would definitely expect questions like this to calculate it. They do for the REMAC, they do give you a calculator, but they're not going to give you the formula.
Okay.
So the formula is something you need to be proficient in, how to plug in these numbers,
sure.
How to get the answer.
Okay, thank you.
Any questions about any cardiac problems?
Are we going to go over the strips up front?
That I already did, and that was recorded, and it was published in the prior email that I sent out. So we went through all these strips, and all the answers were provided, and those videos are already recorded, and they're on the YouTube. Any other questions?
Yeah, Nikolai, do you have any cheat sheets for us that are going to bring up for the next exam, final exam, or in the future? Anything that you want to kind of like have us focus on? Because this is a lot of material. I'm not going to speak for the rest of the class, but it's a lot of material. Anything specific you want us to focus on?
Define cheat sheets. You mean, are you talking specifically about the A&P final?
Okay.
No, I'm asking you, what do you mean by
sure, absolutely.
A&P final?
Absolutely.
So for A&P final, like I said before, your A&P final will be in person. It's going to be 100 questions. It's going to be multiple choice questions like you see here from all the topics we covered, cardiology, endocrine, lymphatics, and so forth, respiratory, right? The questions are going to be very similar. I'm not going to say they're going to be the same, but the content is going to be like, you're not going to show me a question on the test and say, this was not in the lecture, or this was not went over. So the way I would prepare is I would do these problem sets, and the way I would do them is not by just watching this video and circling the correct answer and memorizing these questions. If you're not sure how to, let's say, calculate the MAP, right? I'm not going to give you a question, calculate a blood pressure 120/90. I might give you some other numbers, but hopefully you know the formula and you will be able to do that. Or I will ask a similar question in a different way with the same content, so hopefully you can answer it. So if you're memorizing these questions, it's going to do very little for you.
Sure.
However, if you are reading this question and you let's say you didn't choose the correct answer, I would go back in the book and I would reread that concept so you understand why that's the correct choice and rationale behind it. Because you may get a question that's asking the same thing, but in a different manner. So memorizing these questions will do you very little to prepare.
Yes, of course.
But what I would do is I would print out all these questions, try first to answer it yourself. Then, you know, watch the videos to see where you are for, you know, did you get them right or wrong? Let's say you got, you know, certain questions wrong, then I'll go back in the book and reread those specific problems.
Sure, absolutely. Thank you.